I am Dr. Keyur Parikh, Chairman and Interventional Cardiologist at CIMS Hospital, CIMS Hospital, Ahmedabad, Care Institute Medical Science, Ahmedabad. We are one of the largest group practice in India with almost 20 cardiologists, cardiovascular surgeon, anesthetist, interventionalist, pediatric cardiologist, pediatric cardiac surgeon working together. Today we'll be showing a live demonstration of a right coronary angioplasty in a very complex long lesion and with the background of use of optimal imaging as well as optimal post-dilatation technique and decision making. I have with me Dr. Vineet Sankhla, Dr. Vipul Kapoor and Dr. Tejas V. Patel. All are partners and associate cardiologists at CIMS Hospital, Ahmedabad.
Thank you, Dr. Keyur. Let us come to the case history of this patient. So this gentleman is 48 years old. He's a smoker. He's not a known case of hypertension or diabetes. He presented with effort angina since 2 to 3 weeks. As you can see in the ECG, there are some changes in the inferior leads, T inversions in lead 3 and AVF. There are some tall T's in V2, V3 and V4. Apart from this, there are no significant STD changes in other leads. This is the echo report which shows near normal LV systolic function, and there is no regional wall motion abnormalities. There is no significant mitral regurgitation here. And let us come to the angiography. Now this is the left coronary angiography. This was done by the right radial route with a TIG 5F catheter, and these are the angiofilms. As we can see, the LAD and the circumflex is free of significant disease. There are minor plaques, but what we can see is that there is a RCA lesion. There is about probably ulcerated lesions in proximal to mid, which is extending into distal RCA. It can be acute or sometimes it can be chronic also, but definitely this lesion seems to be the culprit which is causing the patient's symptoms. Dr. Keyur, can you comment on this angiography more about this RCA lesion?
Yes, again, the symptoms are reasonably recent. However, there is no classic ECG finding of inferior MI, or as you mentioned, echocardiogram is normal.
Yes, sir.
So the best option will be to go in with a wire and go ahead. Now before we go in with the wire, let me talk to the audience and viewers about various techniques which we use for radiation protection. Now we use mandatorily almost 4 near field radiation protection on the table. The first radiation protection which we do is once the patient is ready and draped, to do a radiation pad, which are 2 kinds. One by red pad, that is called red block. It's a radiation protection pad by Uniray Medical LLP. And the second is red pad by Horizon Healthcare US FDA approved. Beside these 2, we also use a radial shield, which is very specific, made by a US company, and it reduces further significant radiation. As you see, it's available both for radial access as well as femoral access. It's called CardioTrap by Transradial Solutions USA. You can find the information on internet, which consists of 1 baseboard, 1 shield, radial or femoral, 1 right radial base, 1 left radial base and 1 left arm board, which exactly you are seeing. Also we have a sliding lead shield, the one you see in the black, which is covered, and you also see right next to it in gray lead shield, which is permanently hanging again from the table. So as you see, we have 1, 2, 3, 4. The 4th one, the radiation pad, is still yet to come, which you will see when the patient is prepared.
Dr. Keyur, I just want to ask regarding this CardioTrap. Whether this is available in India, you got it from India?
No, we got it mailed. We got it mailed from USA, but we didn't have any difficulty. We paid them in dollars, and it just came here. You don't need any support. It's just a very simple radiation protection mechanistic device.
I think, Dr. Keyur, these are excellent precautions where everybody should take while doing radial procedures in their cath lab, sir.
Now, as we are starting, almost all our complex cases, we are using slender sheath. Slender sheath is by Terumo. It's called Glide Sheath Slender, and it's a 6 French sheath which is expandable, and it can accommodate 7 French guides. In this case, my intention is to use 7 French guide.
You mean to say, Dr. Keyur, that the outer diameter is 6F, but it will take a 7F guiding. Am I correct?
Yes, you are correct. So this will take in a 7 French guide into a 6 French sheath. So the trauma to the radial artery is not as much.
Yes, Dr. Keyur, and this is particularly relevant to our Indian patients whose diameters of the radials are not as huge as in the Western population.
Correct. Now also with a 7 French guide, if this lesion turns out to be chronic with a dissection, and we have to use different hardwares, including if required more supplies, then 7 French guide can be very useful.
Yes, I agree with you.
As you know that all CTOs we use 7 French guides. Again, the symptoms are reasonably acute, but the long dissected area does suggest there may be chronicity in this lesion.
I agree with you.
This is the red radiation block or a red pad, either of them. You can see it. We put it right on the right abdominal quadrant, extending to the arm.
What this will do? What is the function of this pad?
This also reduces the radiation scatter from the image intensifier.
Okay.
This is a routine 7 French guide going in, right guide. If it is a definitive CTO, I use implants left 1.
Okay. So this is the normal RCA guiding catheter, normal curve?
This is a normal guide catheter, normal curve.
And you have taken a 6F or 7F guiding here?
This is a 7F guiding,
Okay, fine.
which you are putting it in.
Yes. So, Dr. Keyur, after engaging the RCA coronary artery with this guiding catheter, which wire do you prefer as a workhorse? Will you take a workhorse wire here, or you will take some special coronary guide wire?
Usually it's a prudent idea always to start any lesion with workhorse wire, which is a soft wire. In this case, we'll take the run-through wire, again by Terumo. It's a very soft wire and very versatile, and we'll see what happens. I like to bend the wire usually with a slight acute angle, 45 degrees. So that's what I'm doing, Dr. Vineet.
Okay, sir.
So the wire has a nice bend, but a fairly sharp bend, which makes it more torqueable than the gentle curve people are used to making.
So this kind of bend, you make it in all the lesions, or you, depending upon the lesions, you make this curve?
I always make this sharp angle 45 degrees. Only the tip length differs. As you see, I'm already crossing, and I've crossed the wire across the lesion, suggesting very likely it is a softer lesion with a recent dissected right coronary artery.
Yes, the way the wire went smoothly, I think it is acute lesion. Dr. Keyur, one more thing I'm seeing is that you are sitting and performing this procedure. Is this a norm for you? Or means I've never seen, not seen many people sitting and doing this procedure.
Yeah, I've had long-standing spine issues due to doing angioplasty since 1985. So like electrophysiologist, I do sit down and take very adequate radiation protection, as you saw earlier, with leg protection, genitalia protection, abdominal protection, face protection, and body protection. So I always do it sitting down. Now we are opening Dragonfly Optis kit. But before we open the kit, let us pre-dilate this lesion with a 2 millimeter balloon. So we'll go ahead and pre-dilate the lesion with the 2 millimeter balloon so that the entry of the OCT catheter is smooth.
Do you always pre-dilate before passing a OCT catheter, or it's just if the lesion is tight, you'll pre-dilate?
When the lesion is tight, you pre-dilate, but we only open tight lesions. With ischemia trial and many other trials, I think non-tight lesions have to be evaluated by FFR or physiologic testing.
What about OCT, Dr. Keyur? Do you use in every kind of lesions, or any specific reason for OCT here?
Our usage of OCT is about 30-40% of our cases. Of course, in all complex cases, long lesions, dissections, long thrombotic looking lesions, we should use OCT.
Especially in this case when we don't know exactly what kind of lesion this is.
Yes, and it's a fairly long lesion spanning 3 to 4 to 5 centimeter length, and it's a variable diameter artery looking fairly large proximally and tapering off. So in our previous era, or even just few years ago, we used to do judgment and open up the arteries. But in the era of imaging, we should always use imaging.
Okay, so here you are actually going with the OCT catheter. What are the precautions you take while going with the OCT catheters? Any specific precautions you have to take, Dr. Keyur?
Yes, very minimal, but couple of them. One is we have to purge the catheter as the nurse with me, Joel, is purging. And when it's purging, you will see a small jet at the tip of the catheter. Second thing is proper sterility. So you have to use a sterile cover to connect it with the dock. It's called the dock cover. And through the dock, we connect it to the console. So this is a dock. It's an intermediate dock.
Okay.
The catheter is connected to the dock. Through a magnet-like mechanism, it kind of clicks in.
Okay.
So we'll connect the OCT. We have already pre-dilated the lesion with a 2 millimeter balloon. And once the OCT is properly connected, the laser light will start showing up. So right now you see the OCT catheter, there is no laser light. And as it's being connected, the laser light will light up.
Dr. Keyur, one more question. Why didn't you prefer IVUS here? Why you're preferring OCT only? Do you do more of IVUS or OCTs in your intervention cases?
We use OCT more frequently for two reasons. One is the ease of measurement, and the crystal clear imaging capabilities of OCT is so good that IVUS cannot compete with that. And second thing, in some of these very long lesions with variable sizing, the speed with which OCT and the software within the OCT system gives me a lot of information is much faster than IVUS. We use IVUS in either left main, mainly ostial left main, where the dye issue is there with OCT. But there also we have found with good placement, OCT works well. And second is when the patient is nephro with the renal compromise, then we use IVUS.
Okay, so this is the OCT catheter going inside?
So this is OCT catheter going inside. There are 3 dots, the distal marker, which should be reasonably way beyond the lesion. The second mid marker is where the eye of the OCT, the laser eye is placed. That should be there. And we should be totally blood free when we inject with the 20 cc of contrast. So we are starting with the first injection.
Hello friends, I am Dr. Vipul Kapoor, interventional cardiologist, and I will be describing the OCT done for this patient taken for PCI. Now we will be describing the pre-PCI OCT for this patient, Mr. Ishwalal Panchal. Now this is the OCT of this patient from the distal to the proximal vessel. As you can see that this is the tightest portion of the RCA, and in the distal portion where the balloon dilatation was done. Here the minimal luminal area is only about 0.66 millimeter square with an area stenosis of about 90%. Here you can see some dissection flaps produced by the balloon dilatation by the semi-compliant balloon. As we go proximally, now you can see that the OCT shows that there is evidence of some fibrotic lesion, and you can see now again there is evidence of a dissection flap and intramural hematoma, as you can see in these runs, which is very clearly evident. If you see here, you will find partially organized thrombus in the lumen of the vessel, which is typical suggestive of an acute coronary syndrome pathology. And as we go proximally, you can see that you will find the evidence of dissection flaps and the evidence of intraluminal thrombus, and now you can typically see that there is dissection flap and also evidence of some degree of fibrofatty plaque, right, and also intraluminal thrombus. Now we come to the healthy portion of the vessel, and here the vessel diameter is about 3.5 millimeter square. So I would advise Dr. Keyur to take a 3 millimeter stent, because the distal vessel diameter was about 3 millimeter square and 3 millimeter, and the proximal size is about 3.5 millimeter. So we can expand the stent proximally to about 3.5 millimeters, and the length of the stent should be about 48 millimeters, so that we can cover the entire lesion.
And we are taking its CIMS Expedition 3 into 48 mm size, and we have measured by OCT the size. The distal artery was around 2.75 and the proximal artery was around 3, so that's why we are taking this 3 into 48. It was a little more than 3 in the proximal part, so we are taking the average of proximal and the mid and the distal part. So we are taking this size 3 into 48 CIMS Expedition. In our lab we always use US FDA approved stents. So this is the stent which is gone. Well, it was smooth. It didn't require any further maneuvers, though it's a longish stent. We have adequately pre-dilated. This is the stent we are placing it. We have already measured the length of the stent which was required by OCT. This is the stent we are dilating. Dr. Keyur, do you dilate multiple times or you dilate only one time?
I dilate for a long period of time, usually 30 seconds to 45 seconds at nominal pressure or 10% higher than nominal. There have been a couple of trials, one even randomized trial between short inflation and long inflation, and long inflation do indeed lead to better apposition, better expansion. Many a times in calcified lesion, the expansion may not be as adequate, but apposition is almost always uniformly very well in this slow, steady, long expansion of stent.
Okay.
The Abbott's bioabsorbable stents really led us to incremental knowledge on stent placement, which we did not have for almost, I would say, a decade and a half. And what we learned is longer inflations do indeed is favorable, and we do not have to go extremely high pressure unless absolutely required in very few cases. Occasionally I do post dilate second time up to 15 to 20 seconds. After a very long 45-second dilatation, the second dilatation is probably empirical. So many a times I don't do it. If it's a long lesion like here, I would do it. I do see some narrowing in the distal segment. So instead of OCT, let's post dilate using a 3.0 millimeter NC balloon.
Okay.
So let's do the post dilatation. That will save us time later on, because there is a clear cut on a stent boost, some narrowing still remaining.
Dr. Keyur, what is this stent boost technology? Does it really help?
Yeah, stent boot technology really helps, but I use it very infrequently. Some of my colleagues use it all the time. It is basically a technology which gives in much more radiation through the image intensifier, creating much better imaging of the stent. But the hazard is very high radiation dose. So I use it very infrequently, only in complex cases. Now we are done, and let's go ahead with the OCT.
Okay, so here is the OCT which is coming. You can see the 3 markers and the middle marker, which is we are doing the pullback. The same precautions every time we have to take in the OCT. It is very, very important that there should not be any blood in the syringe, because we will not get good OCT images. So the same precaution should be taken every time we do a OCT. So what are the things you see in a OCT after implanting a stent, Dr. Keyur?
What we see after the stent implantation in OCT is multiple things. Starting distally, we see edge dissection. Now, let me caution everybody that edge dissection is increased. We also see and evaluate the stent expansion, stent apposition, luminal area, as well as proximal edge dissection. We will also see if there is anything else intra-stent, like any residual thrombus, any prolapsing tissue. So I would like Dr. Vipul Kapoor to explain the OCT findings. Dr. Vipul?
Okay, friends, now this is the post PCI OCT of this patient. As you can see now, beautiful crisp images of the stent being implanted here, and you can see that this is the stent fly through rendered stent image of the OCT. Now we are going through the tightest portion of the initial lesion, and here you can see that the stent area stenosis is about 31%. So minimal stent area, luminal area achieved is about 4.5 millimeters square with an area stenosis of 32%. So this area definitely requires some post dilatation. As we go proximally, you can see that the stent has been very well deployed, well expanded and well apposed. So there are no major areas of malapposition. And as we go proximally, if you remember, this was the portion of the vessel which was about 3.5 in diameter, millimeters in diameter. So I would advise Dr. Keyur to actually post dilate the tightest portion as well as some portion of the proximal one third of the stent, so that we can achieve a vessel diameter of about 3.5 millimeters.
So, as you have suggested, we will go ahead with 3.5 millimeter balloon and dilate mid to proximal segment, which was showing arterial size up to 3.25. So let's go ahead and place the balloon properly, and Dr. Vineet will start inflating.
So we have post dilated with 3.5 balloon in starting from mid distal part to mid, and then the proximal part of the stent.
And we are going at nominal pressure, even below nominal, lower down, and then as we go proximally, we go higher pressure on the NC balloon, and at the proximal part of the stent where the artery is 3.25, we will go as high as 16 millimeter with the NC balloon.
So, Dr. Keyur, I want to ask one question. How does a OCT after a stent implantation has helped you? Means, what is the difference between a pre-OCT era and this OCT era in implanting a stent?
It is like day and night. In pre-implantation era, it was all experience, judgment, and very likely the outcomes may not have changed as much, but the quality and the precision with which we do our cases has significantly become better. Like again in this case, going ahead with a 3.5 balloon and post expanding to a higher pressure can only be achieved with the confidence of OCT and making sure that the edge dissections, if they are large, and if sometimes not seen on the angiography, are tagged properly with another stent. So now we'll have another run of OCT and check the final results, hopefully the final results. So let's get ready with our OCT and prepare 20 cc syringe. So Vipul, why don't you wind up and tell us what we have found in our this run, presumably final.
So this is the final OCT run of this patient following non-compliant balloon dilatation of the stent, and you can see that this is the rendered stent fly-through image on the OCT. Running from the distal to the proximal segment, you can now come to the point where it was the tightest stenosis with an area stenosis of 30%. Post NC dilatation, you can see that the area stenosis has now come down to 21.8% and an MLA of 5.39 mm square, which is very well acceptable. The stent otherwise appears very well dilated and well apposed. There are no major areas of malapposition. You can see that in the running images, you can see longitudinally and in the cross-sectional view that the stent studs appear to be very well opposed. Now this is the proximal segment of the vessel where we had again post-dilated to achieve a diameter of about 3.5 millimeters, and here again you can see that the vessel area is about again 3.5 millimeter diameter and an area of 7.35 millimeter square. So an excellent result confirmed by OCT after the post NC balloon dilatation, and a beautiful OCT image and achieving an optimum result of stent deployment. Excellent result. Thank you.